Well, I'm talking today to Tony Dobell. Dr. Dobell is a Canadian. He was born in Montreal in 1927. He was born in the hospital that he has worked in all his life. He went to McGill University, graduated from McGill Medical School in 1951. After an internship at the Montreal General Hospital, he went to Philadelphia and completed his general and thoracic training with Dr. John Gibbon. He returned to McGill University on the faculty in 1956, and by 1973 he had been promoted to chairman of the Department of Cardiovascular and Thoracic Surgery. He was also surgeon in chief at the Montreal Children's Hospital. Throughout his career, he's been active in both pediatric and adult cardiac surgery. He's a member of numerous professional organizations. He has served as president of the Society of Thoracic Surgeons and also the Canadian Society of Cardiovascular and Thoracic Surgeons. At present, he is emeritus professor of surgery at McGill University, and today he's going to tell us about his life, his work, and some details about the first use of the heart-lung machine in the 1950s. So I'm going to ask Tony to begin, if you'll tell me about your family and your parents and growing up in Montreal.
Well, my father died when I was 12, suddenly. My mother was, she sort of let me bring myself up. She was an artist, and she was a very stimulating woman, very original. And I think I responded to this self-education. She used to tell me that, you know, I should get out more and have more fun, and not study. And I kind of sympathized with that, but I perhaps I was kind of boring or dull or something. But I did a lot of things when I was going to university. I was involved in a lot of extracurricular activities. I played on the McGill hockey team, which was one of the great feats of my life, I think. That was a terrific experience over quite a few years. So I guess I didn't have much paternal influence on me. And whatever I did seemed to work out pretty well. And I went to McGill. I'd done well in mathematics, and I thought, well, that was the era of nuclear physics and all that. I thought I wanted to be a physicist, and I actually worked in the atomic energy plant of Canada, the research station, in the exciting years of 45, 46, something around that, in the summer, you know. At any rate, I also had an experience there working for the government, and that was kind of negative. And when I was attending medical school, undergraduate school, I worked one summer as a lifeguard. I met an older gentleman from Philadelphia. He's actually a judge. He was probably in his 70s, and he had helped another young student through medical school at Jefferson. And he wanted to help me, but I said I actually had a scholarship at the time, and that wasn't a problem. But he introduced me to this previous surgeon, Joe Stamen. I don't know if you ever knew Joe Stamen, a member of this organization, the American Association. And so I visited Philadelphia subsequently when I went to medical school at McGill. I visited Joe in Philadelphia and had the occasion to meet Dr. Gibbon when I was a medical student at McGill. And so it was that after graduation, I became interested in surgery. I wasn't terribly interested, or I hadn't focused on surgery during my medical school career. But in those days, of course, we had the rotating internships. And it was during that period that I became very impressed by a single surgeon, actually. There were a number of surgeons who were not that impressive as individuals, but there was one who paid great attention to his patients and performed with what I took to be the admirable interest in his patients and in his surgical technique, which was rather meticulous.
Who was that?
Well, his name was Kaufman, Mark Kaufman. He's not a well-known surgeon, and he was, this was in fact in a rotation in a smaller center. Mm-hmm. At any rate, having become interested in surgery, I wrote to Dr. Gibbon, whom I'd already met, and of course, it was the opportunity to work at Jefferson that really created the opportunities for me.
Were you aware of his work with the heart-lung machine at that time?
Yeah, I was.
Yeah, were you particularly interested in that? Or?
I was.
Yeah, so...
It's funny, because I was just a medical student and hadn't done anything. Or I was a resident, and certainly, or an intern, rotating intern. But I had read those papers about the heart-lung machine, which, of course, the original heart-lung machine that he published in about 49 or so, after he returned from the South Pacific, was a pretty horrendous Rube Goldberg apparatus. It only became refined after IBM became involved in the person of Mr. Watson.
Do you know how that came about?
I think it was a chance meeting. Mm-hmm. In fact, I believe it was one of the residents or students at Jefferson who somehow brought Dr. Gibbon to the attention of Mr. Watson, or vice versa. And Dr. Gibbon had an interview with the older Mr. Watson. I guess he was Thomas, but I'm not sure. And as a result of that meeting, Mr. Watson said that IBM would support the development of a heart-lung machine, and they would have no commercial interest in it.
Right. That's a great point, I think.
They would have no commercial interest. They would not produce it. And from what I could see, the commitment was total. I mean, they committed 3 or 4 of their bright young engineers, including one who, as I recall, was one of the original quiz kids. In the 30s, they had those programs, and there were some unusual young people on those question programs, and this was one of them. At any rate, they made this commitment, and they produced the working model of the heart-lung machine. I guess that was produced about 1949, 50. And they changed, of course, the rotating cylinder oxygenator to a vertical screen oxygenator. And that machine was used in the laboratory probably in 1950 and 51. 51 and 52, probably. And then it was used on the patient in 1953 in May on Cecilia Bavilac. But I'm getting a little ahead of my story. But I joined Jefferson, the Jefferson Surgical Residency in July 1952. And I did the first year of residency on the service, rotating through the wards and the private area, and through the tuberculosis hospital, the TB hospital, where I worked with Jay Ankeny, actually. Jay Ankeny was my mentor who showed me through my first thoracotomies. We did a lot in those days for TB still, you know, in the 50s, 52 that was. But in 53, oh yes, she was operated in May 53, and that was towards the completion of my first clinical year, from July 52 to July 53.
Oh, yes. Right.
And when Cecilia was operated upon, I was actually at the TB hospital down the street, and my role was insignificant, but I was the babysitter during the night.
Oh, I see.
I was allowed to come up from the TB stand and sit beside her, but she was an 18-year-old girl who'd had an ASD repaired, and she was doing pretty well. So I didn't have much to do. But of course, in those days, there were no intensive care units or special facilities for intensive care, nor was there any intensive care. There was nothing intensive about it, you know. There were no indwelling lines. You took the blood pressure with a cuff and so on. And so she fortunately got through quite successfully.
Was there very much sort of publicity about that at the time?
No.
It wasn't in the newspapers? Wasn't
I don't think so.
Yes.
I don't think so. And
Wasn't
of
a
course,
big
Dr.
announcement.
Gibbon never wrote about it for about 3-4 years.
Well, that's right. Yeah.
Because I think he was so concerned about the others that were done that
Tell me
didn't
about
do it.
those. Yeah, that's sort of an interesting term.
I think there were 4 others, little children. Jefferson was not a cardiac center, was not a pediatric center. It didn't have anesthesiologists. Did not have anesthesiologists.
And nurse anesthetists.
Nurse anesthetists, very capable, but we, the thoracic surgical service, intubated the patients before they were put to sleep. And I think that was a huge failing. And they subsequently introduced anesthesiologists, probably that was 1954. The diagnostic studies were done by one of the surgical residents using ureteral catheters. And of course, they were only right-sided studies. And you'll remember that doing the oxygen tensions by Van Slyke took about an hour or 2. So everything was kind of retrospective. Suffice it to say that the diagnoses were not perfect. One of them had a large duct. The focus was still on atrial defects, but I think one had an AV canal, and one, as I say, one had a large duct, and the lungs were just flooded, and the whole operations were quite ponderous. They were done through what was called a suitcase incision, transsternal, through both chests. So, suffice it to say, they didn't work out, and that was the end of Dr. Gibbon's experience in doing heart surgery.
Yeah. So he gave it up after that.
Mm-hmm.
And one of the problems was incorrect diagnosis. More was the problem. Was coagulopathy a problem also?
No, the coagulopathy was a problem in Cecilia's case because not quite enough heparin was given.
Tell me about that.
Well, towards the close of her period on the bypass, the oxygenator began to clot up, as I was told. I wasn't in the room, and it was a kind of near thing that they terminated the bypass with the defect closed, and no catastrophe. So the there wasn't a general coagulopathy, but the dosage of heparin hadn't been perfectly worked out. Jefferson was, as I say, it wasn't a real cardiac center. We did an awful lot of pulmonary surgery. And Dr. Gibbons' operation was a pneumonectomy. I mean, he was an excellent pneumonectomist. And that was all a result of the fact that the bronchoscopies were done by Louis Clerf, who succeeded Chevalier Jackson, the great endoscopist.
Right.
So there was an endoscopy service, or bronchoscopy and esophagoscopy service, and there was a thoracic surgical service. The thoracic surgeons did not do the endoscopy. But nevertheless, it led to a tremendous number of referrals. And the pneumonectomy was done virtually every day, every day. And an esophagectomy every week, one a week, which was a horrible experience in those days.
Yeah, I bet.
It was catastrophic, you know, the survival rate. I had the unpleasant experience of following the esophagectomy patients, and the number of survivors at 3 years was in the single digits. So we had a horrendous mortality rate from the operation too, I think of the order of 30%, something like that in those days. Largely due perhaps to the lack of intensive care. We, the residents, had to make rounds every 2 hours at night and work all day. And those rounds consisted of aspirating endotracheal suction to try to prevent atelectasis and pneumonia. So we'd wake up the poor patient, pull out his tongue, introduce a tube into the airway, flush it, aspirate it, and inject saline, try to suck out the secretions. That was the intensity of intensive care. They'd be up, you know, one would be on one floor and one on another floor. It was unpleasant. Then we had the ward experience at Jefferson, which was the same old wards as laid out by Florence Nightingale, kind of wards you saw in the photographs of the Civil War. Here were big, long wards with 40 beds, and each bed 6 feet from the next bed. And our patients would have decreasing magnitude of operations as you went down the ward. It was general and thoracic surgery. So the first patient would have had a mitral commissurotomy, and then there'd be 3 lung resections, or 4 or so, and then you'd get to the gastrectomies and the cholecystectomies, and down at the end you'd have the appendectomy or hernia repair, you know. Those are the wards, and it provided great experience for us, but it's a far cry from the system today.
Was residency then, it sounds like that was fairly intense then. What sort of hours and days did you work?
Oh, all hours. I think we
What was
worked
your
every
schedule?
second night we were
Yes.
in the hospital. We had pretty long hours. We'd come in at 7 in the morning, or I think I did. I had a fellow resident who came in about 6 every morning. He was terribly eager. But I lived over in New Jersey. I took the bus in, and was on the job about 7. And we'd just start the cases at 8. We'd make rounds first, of course. And then you were there till at least you were there that day, that night, and the next day. Had emergencies at night and so on. And these rounds, resuscitative rounds. Then I'd go home, and we were beginning to have children then. Sometimes I wouldn't see them for quite a while, even though I slept in the same house or apartment. My wife told me that my son hugged the milkman and called him daddy once. That was a little traumatic. But as you think back to those days, they were good days, you know? And I think my wife looks back on them not unpleasantly. She knew I wasn't around too much, but she was busy. Well, of course, I was in Philadelphia for 4 years, and we had 3 children. So she was getting pretty occupied. But we were young, and I often think of the poem of Wordsworth, "Bliss was it that day to be alive, but to be young was very heaven." And it was, because the times were so exciting, because you see, in my second year, I was in the lab. Second year. I had a 4-year residency and 3 clinical years only. General and thoracic. Dr. Gibbon, obviously, did not rate technical prowess as the top requirement for a surgeon. That was clear. He did not have much surgical training. He went to the Mass General with Churchill and worked in the lab. His role model was Landis, the physiologist. He worked with him. And of course, he accomplished a great deal in the lab with his wife, Maley, who was Churchill's research assistant, but became Dr. Gibbon's assistant, and then became his wife. And occasionally, one of us residents might look up his CV and try to see where he got his surgical training. But, you know, in the 30s, things were different again. And Dr. Gibbon had the most incredible knowledge and breadth of knowledge about surgery. And to hear him when he was the professor and chairman giving a talk on any subject, including, you know, hip fractures or whatever, was just, to me, it was incredibly impressive. I remember having lunch with him once when at a meeting of the American College. This would have been a few years later, and he was giving a talk right after lunch on pulmonary edema. You know, it's sort of an esoteric subject for a surgeon. And all I know is we had a very full lunch, and it wasn't on his mind at all, and he wandered over and gave a great talk. He was a student, and he was an editor. Being an editor of the Annals of Surgery was, I think, the job that he took the most pride in. Well, besides being the Gross Professor, Samuel Gross Professor at Jefferson, which his father had. His father had that same position, which is quite a tradition. But Dr. Gibbon was a great editor. I knew that because I often came into his office late in the day, and he'd be reviewing manuscripts and dictating his reviews. And he read every manuscript submitted to the Annals, and on occasion, as he told me, he would have 3 reviewers, all unanimous one way, and he'd go the other way and accept it or reject it and write a full report. Not that that would happen often, because he had extremely competent reviewers, but he made up his own mind. He was a poet. He was a poet. He was a student of language. I think he wrote poems. He was at Princeton when he was at Princeton. He was later an artist. Perhaps for that reason, because my mother was a very artistic woman. Maybe we had something in common in that way, but he was very good to me. I mean, as a young resident, I would go to his house when he had a constant stream of visitors, whether it was Dr. Blaylock or Dr. Crawford or Dick Varco, I remember, people like that, and for a young resident to be able to meet these people was a great experience. So he was very kind to young people. It occurred to me later that I was the only one there that went there to learn about heart surgery. Well, I really didn't learn any heart surgery at Jefferson, but I certainly left Jefferson with a commitment to engage in heart surgery. As soon as I went in that lab and began working on dynamic structures, first the femoral artery to cannulate it. I mean, a little thing in an animal, as you know. But then working on the heart. See, I was in the lab in my second year of residency, and I was on the heart-lung machine project, and we made ventricular defects with a cork bore, and then we'd repair them. And I had a lot of leeway. I mean, I was making these defects in these animals, unfortunate animals. We'd do a little right ventriculotomy and apply the cork bore with a suction on the end of it, suck out a meatball of septum, and then a few weeks or a month later, we'd repair the defect. Well, Jefferson was rather a regional medical school, a great medical school, an old medical school, founded about 1820, one of the oldest, and a great medical school, and a great surgical department, traditionally, I mean, we think of Gross, but there are a lot of names associated with it. The famous, who's the surgeon with superior sulcus tumor resection? Superior sulcus, Pankos. But there are a lot of other names that you would recognize on the surgical faculty of Jefferson. At any rate, the students came from around the area. There weren't many that traveled to Jefferson as I did from a peripheral area to do a residency or a studentship. In fact, the residents were all former students of Jefferson. So it's kind of a regional school, and most of the fellows going into surgery were wanting to go back to Wilkes-Barre or wherever and practice surgery, which they did extremely well. It was an extremely good surgical residency, but it was not a preparation for a career in cardiac surgery. Of course, in those days, there was no cardiac surgery. We did at Jefferson, as chief resident, some pulmonary valvotomies, some ductuses, some coarctations, just a few. I didn't learn heart surgery at Jefferson, but I did have the opportunity to work with an extraordinarily capable surgeon in the place of John Templeton. John Templeton had a marvelous surgical ability, and he did all the toughest cases. He made them look easy, something I never could do. So, and John, I regard him as a tremendous mentor. I regard Dr. Gibbon as the teacher. John showed surgical technique of an amazing caliber. And there was another surgeon, George Willauer, who taught us how to look after people. He was a humanist.
Now, was John Templeton on the faculty then?
Oh, yes. He was a partner of Dr. Gibbon.
Oh, I see, yeah.
Was Gibbon, Albritton, and Templeton. John.
And Templeton inherited the cardiac surgical work.
He certainly did. Rather than inherit it, it just lay fallow after Dr. Gibbon's short series. And no intracardiac surgery was done for a couple of years. And then I think it began, I guess, somewhere done when I was a chief resident in 1956. And although I lay no claim and haven't mentioned this, the fact is that after I returned to Montreal in '56, I flew to Philadelphia a few times because John Templeton asked me to come. So I would kind of help out, or I don't know. He felt better with me there, and I felt better for being there, but he was the surgeon. I certainly wasn't the surgeon. I don't think I looked after the heart-lung machine, but he may have wanted me there for something to do with that. We had very good technical help with the heart-lung machine who worked with it in the lab. I'm talking about the old Mayo Gibbon machine, you know. At any rate, things progressed after that, and of course, I went home to Montreal, and I had been at the Montreal General Hospital and felt an affiliation to it. I did my internship there, but the chairman of the department there had no interest in cardiac surgery or in, as I volunteered to do, to work in a lab and try to develop it. He said, surgeons don't work in labs, they work in the OR, and that's ridiculous. But then I went down the street to the other hospital, the Royal Victoria Hospital, where the chief surgeon said, that sounds like a good idea. You come and work in the lab. He gave me a lowly position on the faculty. It's not official faculty. I think I was a teaching fellow. Maybe got paid $3,000 for a year, something like that, maybe less. And I started to work in the lab. Well, of course, you need some support to work in the lab. But at any rate, the support came very quickly from the Children's Hospital because David Murphy was the chairman, was the surgeon chief of the Children's Hospital and had been doing the closed heart surgery. And he was an expert in pediatric cardiac surgery as it existed at the time. And he said, I'll teach you how to do closed heart surgery. You get us into the inside of the heart. So we formed a liaison, and he had associate Gordon Carn, another surgeon who worked with him. And so it was that I would at first help them, and then they would help me do ducts and cohorts. And we worked together to develop heart surgery. We used to do some extraordinary things because we would put animals to sleep in the animal facility, which was separate from the hospital, put them in the trunk of the car, drive them to the hospital, bring them up a freight elevator in the evening, and then do operations on the animals in the actual patient operating room.
Couldn't do that today.
No, couldn't do it today. And then transport them back in the trunk of the car to the animal facility and look after them there. So this involved me pretty heavily, so I can't recall what we started with the bubble oxygenator, which was a most horrible machine and noisy.
I was going to ask you what sort of equipment, pump oxygenator equipment.
We started with the bubbler.
Did you have a roller pump?
No, we had the finger pump, Sigma motor pump, which was constructed for the milk pasteurizing industry out in Minnesota, I think, which is why it was available to Dr. Lillehei. It was a terrible pump.
And you used the oxygenator like he had devised.
We made the DeWalt oxygenator, I guess,
out of
with
your
a
own
coil,
yeah.
sprayed in anti-foam in the top, and had steel wool in there to sort of coat with anti-foam. Yeah, it was a pretty horrible machine, and our results were terrible. The first 5 cases, I think. Not because of that machine, but just because of everything, particularly the fact that cardiologists wouldn't let us operate on anybody until they were pretty darn sick, almost
Yes.
moribund. We did not have the gumption to do a good case, for example, a simple VSD. They had to have a lot of pulmonary hypertension and, right heart failure and so on. At any rate, my memories of those cases was pretty sad. But then we got a screen oxygenator made by the Mark company, Mark IV screen oxygenator, which was somewhat resembled a cheap Mayo Gibbon machine. It had a screen oxygenator, roller pumps. I think the heart-lung machine sold for about $4,000, as I recall it. Was made around Boston. And we felt better with that screen oxygenator. And we began to do better. That was about 1958. And of course, still we started with very difficult cases. But in time, thank God, things improved.
You co-authored a paper with Arthur Weinberg in that period of time. Tell me about Dr. Weinberg.
Well, Dr. Weinberg, he was the first to receive a PhD in experimental surgery at McGill under Dr. Archibald. And so he had a commitment to experimental work. He came up with this extraordinary idea of implanting the internal mammary artery into the myocardium. And it was effective. We have to say from the beginning that that operation did bring some blood to the heart of patients with angina. But I digress a bit because I'm talking about the operation that he devised and not about Arthur. Arthur was, he had the problem of having an ego that had to be maintained. He didn't take criticism very well. He had a lot of energy. He had a strong commitment to his operation, the internal mammary artery implant. And he was emotionally very attached to that operation. And when it was obvious that the operation didn't bring immediate relief, because obviously the implant had to arborize and nourish the myocardium around it rather sluggishly. So it took probably a couple of months before the benefit of the operation was realized. He began adding other things. The omental flap, for some reason, had something to do with bringing more blood to the heart. And I think he damaged his operation by tinkering with it. Of course, his internal mammary implant was done before coronary angiography was available. So the fact that he might tighten a hiatus hernia at the same time and relieve a little some chest pain that may not have been ischemic was often mentioned by people. But he didn't do that all the time. I mean, he did his operation. It had to be a big operation for Arthur, so it had to take a long time, and it took him about 6 hours, you know.
He used both mammary arteries.
No, he used one.
Oh, just one.
We used both.
Yeah.
I began putting in two mammary. I had to do something a little different. Arthur was difficult to work with, and Arthur had his own service. He had a resident that he hired, and he was within the surgical department. He just had his own little service, and he had an operating room a couple of days a week. All that because he was difficult to work with. He was a wonderful host, and very hospitable, and he could be charming. But when anything went wrong, it was somebody else's fault. It wasn't my fault, but it would be a nurse or a resident. Because I really didn't work with him very much. I was a friend of his and a neighbor of his. And we got along very well. I think he needed me to do some things because we began, as you say, doing intracardiac surgery at the Royal Victoria Hospital a couple of years after we started at the Children's Hospital. And so we needed each other. And we were almost neighbors. Later on, we became neighbors. He was always charming, but he believed in a sort of hierarchical system, and he treated the people at the bottom pretty poorly. I think he treated his operation pretty poorly because he kept modifying it, and yet the implant was effective, and I think there's no doubt Mason Soames put the implant on the map because he did the angiography on the internal mammary that had been implanted and showed that it arborized and nourished the myocardium to some extent. Sometimes. Didn't always work. But so I was a great admirer of Arthur in many ways, and also recognized his limitations.
He lived to see coronary bypass, but I suppose that was after his active career.
I think so. I don't recall when his career ended. He was indefatigable, Arthur, and he was certainly working in the late 60s. But I don't recall. I don't recall that he certainly wasn't involved in any coronary bypasses clinically. He was difficult to work with. There's no doubt about that. Younger people found it difficult because it was always somebody else's fault when things went wrong. And
now, during that time, you divided your activities between congenital heart disease and adult cardiac problems.
I began at the Montreal Children's Hospital, and we did congenital surgery, where open heart surgery at that time was going, and then we began to introduce it when with Arthur at the Royal Victoria Hospital. But then there was a change at the Montreal General Hospital. A new chairman was appointed, Rock Robertson, who subsequently, within 3 years, became the principal, that is to say, the president of McGill University. So he was a magnificent gentleman, and he revolutionized surgery at the Montreal General Hospital. And he invited me to join Harry Scott, who was a cardiothoracic surgeon at the General, and who remains one of my very good friends, to go to the Montreal General Hospital and bring in intracardiac surgery. So we started at the Children's Hospital, briefly at the Royal Victoria Hospital with Arthur, and then also at the Montreal General Hospital. And then subsequently I went back to the Royal Victoria Hospital. So I think of myself as a McGill surgeon, a university surgeon at the 3 hospitals. I still have appointments at all 3. And I tried to bring them all together, and we did, into a single training program that was it was the first McGill program in any specialty. Other programs were hospital programs. Subsequently, they all became McGill programs, but we were the first because, by necessity, I suppose. But so I've always thought of myself as a McGill man, and we went to, as I say, we worked at the General, then I went back to the Royal Victoria, and eventually we had a training program, McGill training program in cardiovascular and thoracic surgery. And then some years, quite a few years later, the vascular became separate, which was appropriate because, let's face it, when you're doing cardiovascular thoracic, the vascular was getting a short end of the stick. I mean, the cardiac cases were done at 8 in the morning, and the others were done, you know, in the afternoon. So it was appropriate. We weren't doing as good a job in vascular as the pure vascular people did subsequently. We did what we could, and we learned a lot. And I must say, before coronary bypass came in, it filled out our schedule. But of course, coronary bypass became popular about 1970, I think, as I recall, and that began to inflate our schedule, and and we became quite busy, or our associates did, because I never had quite as much commitment to it as they did, because I was always interested in the children.
One of the operations you reported on a good bit about in the early '60s was aortic valvuloplasty. Tell me about that. Was that mainly decalcifying and that sort of thing, reconstructing?
Yeah. We tried to save the leaflets because we didn't have a good substitute, and we'd spent a lot of time chipping calcium out of the valves. And of course, that was a palliative operation. The patients subsequently required valve replacements. We started off in valve replacements with Henry Bonson's cusps made of Dacron. That was about 1960. 61, we'd sew in the individual cusps. And they looked pretty nice for a while, but of course they stiffened up and tore. So we got to valve replacement, well, as everybody did in the early 60s. With the
using star valve.
Star valves, yeah. Yeah, we sort of grew with the specialty. We went through those wonderful years when every year the annual meeting of this society, the American Association, was just a blockbuster, and you learned of totally new areas that had been invaded by the surgeons and new operations. And we contributed to some extent. We were sort of second-ranked characters, I would say, in the great scheme of things, but we'd come up with a new operation every now and then and apply it. And of course, in those days, you'd have a series of 10, and that would be a pretty good series of something or other. We were all learning from each other, and thank God that those nightmare days are over. Nowadays the risk is so much less, but in those days we had to live with these patients. I can recall, as you probably can, I mean, we'd give our own blood to the patient in the intensive care unit, such as it was. I mean, we didn't even have intensive care units initially, but they were introduced because of heart surgery, and we gradually learned our business.
Now, you mentioned something when we were talking about the character of the real pioneer cardiac surgeons. Tell me what you thought about that. The Charles Bailey.
Well,
type
some of them,
surgeon.
I think it took enormous gumption to be the real pioneers, and some of them just went ahead almost regardless of risk. One of them was certainly Charlie Bailey. I think some of these people were very, very difficult individuals, interested only in getting a few patients through. And of course, I knew Bailey's initial series of mitral commissurotomies. I mean, I used to go and visit Charlie Bailey because Jefferson is not far from Hahnemann, where Bailey worked. And when I was in the lab in that second year, I visited Dr. Bailey, and I learned a lot of things over there. But I saw some appalling things too, you know. That was the era. Huge risks were taken. The mortality rate was very high. Charlie Bailey could talk of an experimental series before he talked of the clinical series, all on patients. And you could do that in those days. I mean, there was no solution to aortic insufficiency, for example. So he came up with an operation where he put a monstrous tie around the aorta under the coronaries. Now, if you think of that route, it has to go in the left atrium and out again and under a couple of coronaries. And back in 1953, I mean, that was pretty horrendous. And I think it's one of those operations that led to what he called an experimental series and then a clinical series, and then he switched to another technique, you know, it was kind of lost. So he broke the, he led the way in many ways for closed heart surgery. He pushed it probably beyond where it should have been pushed. So I think it was appropriate that he went into law later on. He became a law student.
I remember that, yes. I had a couple other questions about Dr. Gibbon. Dr. Gibbon, of course, had a heart attack, and then in the last year of his life, he clearly had symptoms of angina and ischemia and was advised to have an arteriogram. Why do you think that it would have been so perfect had he had a coronary arteriogram and had his own device solve his problem? Why do you think he didn't do that?
Well, I kept in close touch with Dr. Gibbon, but I was not aware of his symptomatology. Dr. Gibbon died on the tennis court in what was it?
I would say
71?
72, maybe.
71 or 2.
Yes.
I, of course, often played tennis with him. When we went to meetings, I played tennis with him. I was never aware that he had angina. So I never discussed it with him. So I really wouldn't comment on why he didn't have a coronary angiogram.
Now, the second question, he was nominated for the Nobel Prize, but didn't receive the Nobel Prize. Do you think he would have in time for the invention of the heart-lung machine?
I thought he should have, but I was close to it and to him. And I've heard rumors about, you know, how close he got to it, but I really have no idea. I think he deserved it. And, only, as you know, only about 3 surgeons have got it. And one of them really wasn't a clinical surgeon. That's, who am I thinking of? Carell, Alexis Carell. He really didn't do clinical surgery. Hufnagel was a surgeon who got it. And I guess Joe Murray, did he get it later?
Yes, he did. Mm-hmm.
Yeah. Well, I always thought Dr. Gibbon would have been a great Nobelian. He was an incredible speaker at meetings, as maybe I've suggested, you know. He just had an easy way of expressing himself. He was a great teacher.
Now, you also published papers about Maud Abbott, and
Yes.
she was the first pediatric cardiologist, I suppose.
Yes, she was.
Tell me about her.
Well, Maud Abbott graduated not from McGill University, which would not accept women in her era, did not accept them until 1920, I believe. But there was a medical school temporarily down the street, and she acquired a medical education after pressuring the people greatly. I mean, she was a tough woman. And then she went to Europe and acquired expertise in cardiology and came back. Of course, there was very little to be acquired at that time. They didn't know what to do with Maud. She set up shop in Montreal, but she wanted to be on the faculty. She wanted to do something important. And finally, they stuck her in the museum to care for the museum, which was terribly important in those days because we didn't have the visual aids, or they didn't have the visual aids and all like that. So they stuck Maud in the museum, and she began studying hearts. And of course, she had this meeting with Osler. She went down to visit Sir William, of course, another McGill graduate. He was a genuine McGill graduate down at Hopkins. And he told her she should study congenital hearts. And he invited her to write the chapter in his book. So that's how she got hooked. She got hooked with Sir William, and she got hooked with hearts. And she made the first classification of congenital heart disease. Of course, nobody gave a damn about congenital heart disease because there was nothing you could do for it in those days. But she classified it, and she made the first great step. She was a character around McGill. She loved McGill. She loved being part of the academic institution, and she loved medical students. Maud Abbott was, I think, looked down upon by her male colleagues, you know, as Maudie, who worked in the lab. They probably didn't have much interest in what she did, but she classified heart disease for the first time, congenital heart disease, and she was a great stimulus to another gentleman, Harold Siegel, who studied cardiology from a background of working with Maud in the early 1920s. And Harold Siegel was a good friend of mine who died at the age of 90-something a couple of years ago. So we often talked about Maud. He called her Maudie, and she died about 1940. She made a great contribution in that era, classifying congenital heart disease.
Way before cardiac catheterization.
Oh, way. But she did have access to the patients and then to the autopsies. That's as far as it went. She studied the specimens. She was a pathologist, cardiac pathologist, the first one.
Yeah.
And probably because she could find no other niche, and she loved being around the medical school. You know, it was a kind of symbiotic relationship. She was happy there, and they were happy to keep her in the museum, because her specimens, well, it wasn't only her specimens, the whole pathologic museum was the entity in which she worked. She was the deaner, you would call it, of the museum. The specimens were mounted beautifully and so on, and in all fields, but her interest was in the cardiac. And of course, specimens were then sent to her from everywhere, because nobody else was interested. And she classified them. Yeah.
Now, your whole career you spent in a training program, in a teaching program. How would you describe today sort of how do you think a training program should be today? Number of years training for cardiac and thoracic surgery.
Yeah.
It's a 2-year training program, which really seems out of balance, I suppose, to me.
Well, in Canada, of course, it has changed. And for us at McGill, for me, it was always important to remain part of the American system, of the American boards, but we got thrown out of the boards about 10 years ago, 11, 12 years ago. We got thrown out of the board eligibility. That is to say, our trainees were no longer eligible. So that freed us up, I guess you could say, for a new curriculum. And our curriculum now is, perhaps I shouldn't talk about our curriculum because it may not be ideal, but suffice it to say that it changed. Since we didn't have to head for the American board, our trainees did not have to be chief residents in general surgery. And the program became 2 core years, 1 year in the lab, and 3 years of clinical cardiothoracic surgery. And in time, we lost our credentials in pure thoracic, or we are losing them. So we became more of a cardiac training center. That followed from Toronto, where cardiac and thoracic historically had been separate for many years. So that's the way it is now. We have 3 clinical years, 1 lab year, 2 early clinical years to do the basics. That is to say, cardiology rotation, and of course, emergency department and ward work in surgery and so on.
So not so much general surgery.
It's done, those first 2 years are done under the rubric of general surgery, but they are tailored to cardiothoracic. They aren't the same as somebody who is going into proctology would take, you see. They're tailored.
You think it's time that thoracic and cardiac divided and had separate training?
Well, I know in the United States that's a no-no at the present. They want to hold them together, and we wanted to hold them together. I think they could hold together. My own view is that they don't need the chief residency in general surgery, which is the real keystone of the American system still, as I understand it. Our people, you'd be surprised to hear, are selected from medical school. They are selected from medical school, which appalled me, and I've never been part of it because I really retired about 10 years ago from that program. But it's working out pretty well. And I guess there are options for them after the first 2 years. Because after all, how do you know if somebody has the manual dexterity and that sort of thing, and the fortitude and the interest to go into cardiac surgery when they get out of medical school? So I've never really believed in that, but all I can say is the end product is coming through as a pretty strong product. I suppose they're selected on marks or something, which I don't think is the be-all and the end-all.
That happens in our programs also. That
Yes.
students have to decide maybe in their junior year if they're going to go into ophthalmology, which is ridiculous.
They haven't even seen it.
No, don't have any experience, don't know what it's like. It's different.
Yeah.
Well, we've got a couple more questions. One is, you've mentioned several people who influenced your life. I want you to just sort of go through and tell me the people that have had real influence over where your life took turns and where you went. You mentioned.
Well, in surgery, I was influenced, as I said, by my friends at Jefferson, or leaders, by Dr. Gibbon, who taught me knowledge. I mean, he was an incredible student and presenter of information. By John Templeton, who remains a good friend of mine and who taught me operative care, skill. And by George Willauer, another surgeon, who taught me about people. He was a humanist. And he wouldn't treat everybody the same way. He'd treat people according to their own personality. I mean, I recall once being on about the 13th floor, being with him, talking to a patient, and she said she was so despondent she wanted to die. He went over to the window, threw it open, took the screen off, and walked out of the room. Well, you know, that isn't the everyday treatment for a potential suicide, but, you know, she loved him afterwards. So there you go. I mean, George Willauer taught all of us about human beings. So my role models were all in my residency,
Yes.
I would say. Well, no, then there's Dr. Robertson, who came to head the surgical department at McGill and subsequently became what is called the principal, but what you would call the president of the university. He became the president of the university. He ran the whole university in a terrible period when the students, you know, were beginning to occupy president's offices and things. I mean, I think it must have been a heartbreaker. He must have wished he could have been back in surgery. But he was a huge man. And of course, I've had friends. I don't know, I guess we all learn from our friends, associates. We don't look on them as, we look on them as sort of equals, but we learn from all of them, and I've learned from hundreds of them, I guess, seems to me. And I've had a balanced life, you know, I worked very hard, but I've been fortunate with my wife and family, and we all think we've had a pretty full life too at home, although they're all spread far away right now.
So the final question I'll ask you is to speculate a little bit about cardiac surgery for, say, residents in training right now. What do you think the future holds for residents who are going into a lifetime career of cardiac surgery? How different do you think it's going to be? How same do you think it's going to be?
Well, I'm sure it's going to be different. And that's why I always tried to prepare people for the broadest possible careers. So we tried, unsuccessfully in the end, but we tried to combine cardio, thoracic, and vascular surgery. But gradually the pieces were taken off. I think it's very important for a young person to have the greatest possible breadth. So what is the future of cardiac surgery? I have no idea, but everybody is aware that incisions are getting smaller, cardiologists are intervening more, and I think that's good. I mean, if I was going to be operated on through a keyhole and safely, I think that would be all right. So I'm sure that in 20 years, it'll be quite different from what it is today. And I can't predict at all, but I would, if I was a young surgeon starting off, I'd like to start off in a field that was going to open up rather than going to constrict. And I'd like to have the broadest training. I think I'd tried to have a lot of training in cardiology. I'd like to, we fortunately still implant pacemakers and that sort of thing. We do all that. The surgeons do it. I think it's a surgical procedure. I'm not sure that some of the things the cardiologists do aren't surgical procedures. I think we have to work very closely in trying to bridge that gap. We don't want to look on them as them and us as us. I think it's going to be one field. So we're fortunate at home. We work very closely with the cardiologists. They don't infringe on our turf, and well, they do. I guess they take cases away, but I mean, our volume has never diminished.
Well, I think that's an important concept.
You know,
Work together rather
but
than.
I think we should be quite aware of what they're doing, and they have to be aware of what we're doing, because that's where our cases come from. Our cases at home never come directly. They're always through a cardiologist. Our cardiologist. In other words, if they're referred from another cardiologist, they go to our cardiologist. They don't go to us. And that works out well for us. We're busy doing what we do, which is trying to repair these hearts, not writing a whole lot of referral letters, you know, except after the operation, not pre-operative.
Well, I want to thank you then for taking time.
You're welcome.
Tell
Thank
me
you.
about your life and the people you knew and the
It's been happy.
origins of cardiac surgery. It's very good. So
Thank you.
thank you very much.